uh, chest pain for 4 days, right in the right thorax, associating also mild cough without sputum, also vomiting in the past 3 days, some of them with blood. I can give you more information, or I can pass. I can stop there if you want.
So sorry, David. I think I've had a hard, just the audio is not coming across for me as well. Just wanted to make sure I got all the information. So it sounds like it's a 23-year-old woman who's coming in with chest pain for 4 days. For the same duration, she's having some mild cough, but without any sputum, but has had some vomiting. Didn't catch the part about the blood.
Some of the vomiting was with blood, but not all of them.
Awesome. Thanks so much, David, for presenting the case. Maybe I'll tackle the chest pain portion of it, and then I'll pass the mic to Jack to layer on the rest of the symptoms. So, I feel like chest pain is like one of those complaints that when we hear about it, we become tachycardic and anxious ourselves. Whenever we think about a complaint like chest pain, where all I always start is kind of think about, your no misdiagnosis. And I launched the CP Solvers chest pain schema, and especially the emerging causes that you want to think about. And one of the reasons I love it, because it's not only focused on cardiac and pulmonary, but also reminds us that there are esophageal causes. And especially with someone, who's coming in with like maybe some blood, some vomiting, it's worth noting. And those esophageal causes are rupture and impaction. And just like the cardiac, it's like the 4+2+2 model that we've talked about multiple times. For the cardiac causes, we think about ACS, aortic dissection, tamponade, subu. For pulmonary, we think about embolism and pneumothorax. And the thing about these causes, the one that is like tends to be like more acute, and the fact that the symptoms have been going on for 4 days doesn't necessarily exclude them, because usually, 23-year-olds have good reserve. However, thinking about like someone with her past medical history would be informative if she has any other past medical history, congenital things that we should be aware of. But the things to also think about, with younger adults, like kind of carditis, like pericarditis, myocarditis being more common, or is this like chest pain not related to the pulmonary cardiac system at all? And given like some of her GI symptoms that she's experiencing. So I'll pass the mic to Jack to layer on those factors.
Oh, I think, honestly, I think you captured everything that there is to capture at this point in the case, right? With any chest pain, cardiac is oftentimes going to be the center of gravity. It maybe gets a little bit less gravity with a 23-year-old individual, and also when the chest pain has been persistent for several days, and that brings into the fold the pulmonary and the gastroesophageal systems. And I think really all of the morbid diagnoses that you just so crisply took us through are all on the table in the setting of these other features. And so I think, right, oftentimes we're going to say we're going to pass through the cardiac causes as we go into looking at the lungs and the GI causes. And I think in this case, we're actually like advancing all three of them simultaneously, because there are these other features of the coughing and then also the blood-streaked vomiting that are on here as well, which I think the probability of a pulmonary or esophageal cause is made higher by the decreased base rate of acute coronary disease in a young, as far as we know, healthy individual.
So,
all right, David, take us forward.
Okay. So she denied any fever, weight loss, or night sweats. She reported also mild abdominal pain, intermittent in the last week. And the chest pain was pleuritic in nature. Okay. Her only past medical history is peptic ulcer, which she don't know any more information about it. She didn't have any meds. No family history relevant. Social history, her social history, she was from Nigeria, and the last travel to that country was 1 month ago. She came to Spain 1 month ago. I can go with the PI if you want.
Yeah.
The temperature was 37.3 Celsius, heart rate 108, blood pressure 117/57, SpO2 was 96 on room air. She wasn't in acute distress. There was no. She was alert, oriented, and no failure. Yeah, the cardiovascular exam was normal, regular rhythm without any rash or murmurs. The pulmonary exam was she had decreased breath sounds in the right base, and the rest was normal without any other sounds that were concerning. The abdomen was soft, non-tender, and non-distended, mildly tender only in the epigastrium, but not rebound or guarding, and no palpable masses. Neuro exam was okay, and extremities, no edema, no rashes. Yeah.
All right. Amazing, David. Thank you. Thank you so much for this. So I will say that, looking back at the history, the extra history that we got from David, I think one of the things that's the most striking to me is that this process that has now moved to the thoracic space seems like it potentially started in the intra-abdominal space, right? We have this sort of reported history of some mild intermittent epigastric abdominal pain over the course of the last week, layering this on a background of peptic ulcer disease. And now something has moved into the thoracic cavity, and particularly with a pleuritic component, right? So if we just double click on pleurisy here and say, okay, well, what are some of the potential causes of pleuritic chest pain? We can really think about what are the structures that move when we take a deep breath in, right? Because pleurisy just means that pain that is worsened by breathing. And so when we take a deep breath in, there's many structures that are moving. And when those structures are moving, if there is inflammation in or around the structures that are moving, it can lead to this pleurisy. So the first thing that moves when we take a deep breath in is going to be, obviously, our lungs expand. So certainly pulmonary diseases, for example, things like a peripheral pneumonia or a pulmonary embolism, they can cause pleuritic chest pain from the parenchymal process. As the lungs move, when we take a deep breath in, so too does the pleura move with it. And so any pleural-based process, particularly exudative or inflammatory pleural-based processes, can also cause pleuritic chest pain, right? But it's not just the peripheral structures of the thoracic cavities, also the central structures of the thoracic cavity move when we take a deep breath in. So certainly things like the pericardium and the pericardial space, we can see a pleuritic component to that with, for example, pericarditis, like Charmaine had mentioned. The other important structures to out is obviously thinking about the diaphragm, not only the diaphragmatic muscles itself, but also the things that border the diaphragm, right? So to the north, right, of the diaphragm is the pleural space. And then to the south are important organs within the intra-abdominal, the right upper quadrant and the left upper quadrant, right? So hepatobiliary disease and also splenic disease can sometimes sneakily cause underlying pleuritic pain as well. The other thing that I'm bringing into the fold here is if we think about things that could lead to these pleuritic components. For example, we hear decreased breath sounds at the bases, which perks my ears up to the possibility of a pleural effusion, is also then bringing in this possibility of, as we had talked about before, esophageal pathology, right? We have this past history of peptic ulcer disease, knowing that this is somebody who may be at risk for gastric perforation or esophageal perforation if there has been reflux associated with that, especially in the setting of these recent episodes of vomiting, right? Effort-related esophageal rupture in the setting of vomiting is what we call Borhave syndrome, which Yasmin had put in the chat earlier, right? And some of the key characteristic features of Borhave syndrome are potentially on the table here, right? We have pleuritic chest pain, the possibility of pleural effusions based off of the physical exam, but we're missing some of the hallmark characteristic features, right? Subcutaneous crepitus, right? Related to the extension of air from the esophagus and the gastrointestinal tract into the subcutaneous spaces, right? So I think the way that I'm thinking about this as we move forward through the exam is the possibility of a gastroesophageal cause of chest pain continues to move up higher. And potentially that gastroesophageal disease, while it may have started in the intra-abdominal portion of the GI tract, has potentially moved to involve the thoracic portion of the GI tract. Charmise, what are your thoughts?
Oh yeah, I love that. And I think like, in this case, I think like she's like tachycardic, which is an ominous sign always, but afebrile like blood pressure is still good. But again, like I 100% agree, like kind of a Borhoff syndrome is a no misdiagnosis here. I'm very curious why she has peptic ulcer disease. She's 23 years old. Common causes being H. pylori, that is quite common. So is this the common etiology? Does she use like, a bunch of NSAIDs, or does she have alcohol use that is predisposing to peptic ulcer disease? The other way I'm like thinking about it is are we dealing with like not while some of the more rare causes of peptic ulcer disease that can also have some pulmonary manifestations, right? They're like rare infections, like granulomatous infection that can do both, like TB, histo, molds like aspergillosis can do both, viral etiologies, CMV, a little less likely pulmonary finding, and also like inflammatory etiologies, like are we dealing with Crohn's, or like an IBD, as well as the other ones that are kind of less likely, but also is there like a malignancy link, right? Gastrinomas or something like that. So it would be really curious to know, like, this is the peptic ulcer disease run of a mill, like H. pylori, or is it like something a little bit more involved? So that's another way I'm just like thinking about it as we go through the case.
Okay, so I give you some labs and some first imaging. The white blood cell count is 8,000. The hemoglobin was 11.2. Platelets normal. The sodium potassium chloride was normal. Creatinine 0.8. Glucose normal. And the liver enzymes were also normal. CRP was 7.7 milligrams deciliter. And ECG was done and it was normal, just sinus tachycardia with no other concerning features. And the X-ray, I can show you the image if I can. Do you see it? Can you see the X-ray? So that's the X-ray.
Awesome. And David, it looks like there's what seems to be almost certainly a right-sided pleural effusion there, acknowledging that our view may not quite be as crisp. Do you mind giving us the full radiology read?
Yeah, the radiology was concerning for a hydropneumothorax with maybe some underlying lung pathology that was difficult to interpret.
I see. And sorry, you said a hydropneumothorax?
Yeah, right. Hydropneumothorax.
Great. All right. Well, looks like Charmaine popped off here. So I will talk us through kind of briefly maybe some of the labs here, and then also the hydropneumothorax possibility that we're also seeing here. So in terms of some of the lab findings that we discussed, you know, I would say the labs are notable for maybe some underlying systemic inflammation if that ESR or CRP was high. But I think really, right, the crux of this case now, or at least the center of gravity here, is surrounding this chest X-ray finding, right, where we see air and fluid in the pleural space, right? So we have to ask ourselves, how does air and fluid get into the pleural space? And there's a couple ways that this can happen. The first is that some component within the thoracic cavity that has air and fluid in it has ruptured, right? One time where we can see this is if somebody has a lung abscess that has eroded its way into the pleural space, right? That air fluid level in the lung abscess, if that walled off infection in the pulmonary parenchyma is able to pop its way through the lung parenchyma into the pleural space, both the air and the fluid can leak into the pleural space, right? So a hydropneumothorax, both because of limitations of chest X-ray or because of progression of disease, can be related to or actually mistaken for an underlying lung abscess. So whenever you see hydropneumothorax on chest X-ray, we want to at least explore the possibility for a lung abscess, which is usually going to involve cross-sectional imaging. Another way that we can get air and fluid into the pleural space is through the rupture of a structure in the thoracic cavity that contains air and fluid. And if you've ever burped before or ever swallowed water, you know that your esophagus can carry both air and fluid, and it runs through your thoracic cavity. So the finding of a hydropneumothorax also invokes the possibility of something that we were previously considering, which is a possible esophageal rupture. A couple other things that can do it, where you can see a lot of fluid and a little bit of air, is going to be something called a pneumothorax ex vacuo. This is somebody who has a very chronic pleural effusion, and they have actually developed some fibrosis and rind around the lung itself, which limits the lung re-expansion. And when you drain off some of the pleural effusion, right, that lung may not re-expand into the, and so you're left with a vacuum of air in the pleural space. That is usually in the context of very, very chronic, long-standing exudative pleural effusion, which is not the case that we have here, right? So we're contending with a couple different possibilities. One is that some structure that carries air and fluid has ruptured into the pleural space, or that something from the lung has actually made its way and eroded through the lung tissue into the pleural space. If we're going to weigh those two hypotheses against each other, long-standing lung pathology that has now eroded into the pleural space, or acute esophageal pathology that has now led to an esophageal rupture, based off of the history that we have, we're going to prioritize the esophageal component of this, particularly given the pre-existing known peptic ulcer disease, these episodes of vomiting, and then now this finding of a new hydropneumothorax. But that's all the DX component of this, which is going to fall secondary to the TX component of this, right? Which is that there is now air into the pleural space with a way for air and fluid to continue to track its way into the pleural space, right? While she is hemodynamically stable now, we have signs that there is hemodynamic destabilization brewing, right? Both with this developing of underlying sinus tachycardia, and we know that if air continues to accumulate within the pleural space, we run the risk of this hydropneumothorax actually becoming a tension hydropneumothorax. So therapeutically, right, we want to relieve the pneumothorax as urgently as possible, right, with probably a tube thoracostomy. And once we can get the tube thoracostomy in, right, then our diagnostic journey continues. And we have to ask ourselves, well, gosh, how could we decide where the underlying etiology is, right? One way to do that is with cross-sectional imaging, right? We can look and see, is there pulmonary parenchymal pathology that has moved its way into the pleural space, or do we see signs of an esophageal rupture? It's important to note that esophageal ruptures can be challenging to diagnose with imaging. There's a few different ways that we can do it, but oftentimes you need either IV contrast or some sort of luminal study to be able to evaluate for it. We sometimes think about doing things like a barium swallow when we want to look for esophageal pathology. But in this case, a barium swallow, when there's an esophageal perforation, right, the barium can make its way into the pleural space, which ends up being very, very caustic to the lung tissue. So this is one scenario where you would want to reach for something like a gastrographin study, which is a little bit less caustic and irritating to the structures in the thoracic cavity, if indeed some of the swallowed contents leak out into the pleural space. There's other things we can do, like a CT esophagram, which also involves swallowing contrast or some sort of soluble material that allows us to see for any breakdowns in integrity of the esophageal wall. And then we can also test for it looking at the pleural fluid studies, right? If you think about how a hydropneumothorax from an esophageal perforation would be different from our characteristic exudative pleural effusions, there would be the presence of usually things that are present in our saliva and in our GI tract that aren't normally present in exudative effusions. So if we ask ourselves, well, gosh, what is present in the gastric secretions or the esophageal secretions that wouldn't be present in exudative effusions? It's all the things that we use to digest food, right? So you can send pleural fluid studies for things like salivary amylase. And if that's present in your pleural fluid, it also increases the probability of there being an underlying esophageal perforation. You can also look for a very, very, very low pH, right? We sometimes see low pH in pleural fluid studies when individuals have complicated perineumonic effusions or an empyema. But in gastric contents, right, if you're getting gastric contents into the pleural space, that is an incredibly, incredibly low pH, right? So if your pH is very, very, very low on your pleural fluid size, I don't have the number cut off the top of my head right now, but I will promise that I will look it up before we log off. But if your pH is very low or your amylase levels are very high, that also suggests the possibility that you could be dealing with an esophageal rupture here. So that's all to say, right? We have to contend with two possibilities here. Something in the lung with air and fluid made its way into the pleural space, or something from the gastrointestinal tract has ruptured and brought air and fluid into the pleural space. The tempo here suggests that it's an esophageal process, and we can further support that hypothesis with cross-sectional imaging of the chest to look for breakdowns in esophageal integrity, which we can use gastrographin or a CT esophagram to help with, or look for pulmonary parenchymal pathology. And then the second tool that we have is the pleural fluid analysis. And again, things like pleural fluid amylase and a very, very low pH can help you support the hypothesis of an underlying esophageal perforation in this case. So, all right, David, I'm very curious to see where things went from here.
Do you want me to continue?
Say that again?
Do I continue? Yeah.
Yeah, go for it. Go for it. Why don't you go ahead and just take us home in the interest of time?
Okay. I give you some more information that I think not to the final DX.
Okay.
There's some more clues. Well, as chest and abdomen CT was done, and it showed it confirmed the hydropneumothorax. It also showed some small opacities in the right upper lung, and also abundant acidic fluid with soft tissue nodularity in the greater omentum. And a chest tube was placed in the drain bloody fluid, and that acidic fluid analysis, I can give you some of them. And the pH was 7.3. The SAC was 0.4, and there were 1,060,000 red blood cells and 2,300 leukocytes with 52% of mononuclears. The pleural fluid was also with concerning for an exudate with a pH of 7.25. Glucose was 48, and LDH was 600, and adenosine deaminase was 17, and there were also 8,000 red blood cells per microliter, and also 7,000 leukocytes, of which 62% were mononuclears. I can give you a bit more information of the analysis of the fluids. The cytology was negative in both pleural and acidic fluid, and the gram stain and the cultures were also negative, and the PCR for Mycobacterium tuberculosis was also negative in both fluids. And I can stop there, I think, and later give you some more information that will be the last aliquot till the diagnosis.
Awesome. David, thank you so much. I think just to in the interest of time and to be brief here, what I will say is I think what the imaging studies help us with, as do the nature of the pleural fluid studies, is they tell us that that the possibility of an esophageal perforation seems much less likely at this point in time, given the fact that we aren't seeing some of the other features that we would expect to see. For example, subcutaneous emphysema, the fact that there is primarily a right-sided pleural effusion as opposed to potentially, which the esophagus can move its way into the right side. It usually goes into the left side, but we're not seeing any signs of a loss of integrity, at least yet, with those findings. And then the pH is, while low, is not terribly low, which I think also decreases the possibility of this being gastric contents within the pleural space, but I'm not so sure that I can definitively rule that out yet. What does become a lot higher is the possibility of a pulmonary infectious process, particularly given this travel history to areas in where mycobacteria and other endemic fungal infections are where she was likely exposed to them. And so the possibility now, as Darling mentioned in the chat earlier, of some sort of pulmonary, subacute indolent pulmonary process that has now made its way into the pleural space. I think while if before this aliquot, I was very concerned about esophageal perf, less concerned about a primary pulmonary disease, I think those have become much more equal in the underlying probability. The one hallmark here is the fact that we have this soft tissue nodularity in the greater omentum, right? And this still does, I think, raise the possibility, while that TB study was negative, of disseminated tuberculosis, which can make its way into the pleural space. The PCR being negative from the pleural fluid studies does seem like it's has a very high negative predictive value, but sometimes for extrapulmonary TB, particularly in the pleural space, sometimes we actually need a pleural biopsy to formally exclude the diagnosis, or biopsy from somewhere else, right? So I think we have, if we're going to say that this, again, the possibility of an esophageal perforation has gone down markedly, and I think now, given the age, the recent travel history, the finding of these sort of gastrointestinal symptoms that preceded this, the omental findings in the pleural fluid study, some sort of disseminated infection, like a mycobacterial infection or an endemic fungal infection, things like histo, cocci, blasto, or paracocci, start to come up much higher on the DDX. But to be honest, I'm having a hard time saying that I have that there's a lot of features here that prominently prioritize one over the other. So I think in real life, I would test for all of those, acknowledging that the testing may be diffusely negative, and we may have to reach for more invasive studies like a pleural fluid biopsy, or sorry, like a pleural biopsy, or given the omental findings, a peritoneal biopsy. So David, why don't you go ahead and take us home with the final diagnosis here?
Okay, so great discussion. The case was a bit difficult because the pleural fluid was analyzed again, and it also saw, well, the same components as said. The gram, the cultures, and the PCR for Mycobacterium tuberculosis were again negative. Bronchoscopy was done, and the cultures, gram, and PCR for tuberculosis were also negative. In the VAL, and well, gynecology was consulted, and the echo was negative for any ovarian pathology. And finally, laparoscopy was done, and there were taken biopsies of the epiplon and the implant that was seen in the CT, and they were concerning for endometriosis. So this was a case of thoracic and abdominal endometriosis causing hydropneumothorax and ascites. Yeah.
Awesome. What an incredible case. Amazing. David, you have, I think you have brought the house down in the chat. What an incredible case here. Thank you for bringing this to us. One of the, it is always a great moment when something that wasn't even in my mind ends up being the final diagnosis here. And I'm so excited to get to learn more, both from you, David, as we wrap up with the teaching points here, and also with some deep reflection on my own reading. I think particularly because there are some diseases where they're really important to diagnose because of the acute morbidity of them. And then this is one where I think I'm realizing that there is lots and lots of equity and equity issues in the lack of, or my lack of awareness of this diagnosis, right? A very, very common disease that can have a variety of different manifestations that can have hugely limiting impacts on individuals who are already marginalized by many elements of both society and the healthcare system. So I really appreciate you bringing this one to us today. It's a ton to learn from here, and thank you for laying it out the way that you did as well. I think you really held the tension just brilliantly throughout the case, and made this such a rich substrate to learn from. So yeah, David, if you have any reflections to share, please do let us know. And then otherwise we can turn it over to Yusuf for the teaching points here.
Yeah, so well, this was a difficult case because I think the main concern for us was initially TB, given the hydropneuma and the ascites, and given that it was a young female that came from Nigeria with no other past medical history. Well, it was also immunocompetent, but the thing was she didn't report any dysmenorrhea or pelvic pain, but it was very outstanding that the ascitic and pleural fluid were very bloody, and the analysis showed like a lot of red blood cells compared to white blood cells. And well, we were also concerned about a malignancy that well, it would be rare given her age, but yeah, that is a possibility that we think we had to rule out. But yeah, well, finally, the histology revealed endometriosis. That is a bit rare because it didn't have any ovarian or other pelvic implants. But well, after reading after that case, the extrapelvic endometriosis is one of the main causes of right hemothorax that could be catamenial. In this case, that was not very clear, but it's also more frequent, more common in African females. So yeah, well, I think a case also to think in other diseases that we also we commonly don't think about and don't let us guide only based on the origin of the patient and well try to think of other things. Yeah. So well, we think and if you want to do the or use that excuse me, the teaching points.
Yeah, thank you so much, David. What an interesting case, and wasn't even on our differential, and it's very like difficult to make it, especially that it's diagnosed laparoscopically. The teaching points that I had were initially the framework approach to chest pain. We used the CP solvers schema, which is the 4+2+2 framework for cardiac etiologies, ACS dissection, Takotsubo and tamponade, 2 pulmonary etiologies, PE and pneumothorax, 2 esophageal etiologies, rupture and impaction. And then we thought about etiologies for pleuritic chest pain. The framework for that involves things that move. So things that are in the lungs but peripheral, such as peripheral pneumonia, PE, and then anything related to the pleural space, such as pleural effusions. On the other hand, things that moves in the chest is like the heart and the pericardium. So pericarditis on the differential. And then the last thing that moves is the diaphragm. So things that are touching the diaphragm or abutting the diaphragm, whether intra-abdominal or in the pleural space. We also discussed whether we should include the peptic ulcer disease as part of our diagnosis and whether it's related to the eventual diagnosis. So we talked about pulmonary and ulcer, pulmonary syndromes that cause ulcers as well. So we talked about infectious causes such as TB, histo, and fungal etiologies, viruses such as CMV, and then malignancies as well. Lastly, we saw the image which showed the hydropneumothorax. And when we see a hydropneumothorax, in general, we should think of, could there be a structure that ruptures, for example, an abscess, an esophageal rupture, or a pneumothorax ex vacuo? And then we discussed the diagnosis of a esophageal rupture through pleural fluid sampling, and that can be through finding an elevated amylase or a pleural pH less than 7.3 can also help the diagnosis of esophageal rupture. And that's all I had. Thank you all for a wonderful day and a wonderful session. Have a good day, everyone.